Today I'm going to present a case of pediatric traumatic cataract. How to do the case when you have... Oh, okay, sorry. So the purpose of actually presenting this case is, especially during the COVID times when most of the cases were treated in the periphery, some of the penetrating injury cases had to be empirically treated or managed medically, and then they turned up with adherent leukoma, phimotic people, and it was difficult to manage those cases surgically. So considering this as a challenge for those young ophthalmologists who have come up, so I wanted to present. So can I go ahead now? Yeah. Yes, thank you. I do not have any financial disclosure for this presentation. So as you all know, traumatic cataracts do compromise the visual outcome owing to the damage that they has already caused to even the other ocular tissues. These are some of the morphological characteristics of traumatic cataract that I have presented. The first one is a rather straightforward rosette. The other one with penetrating injury of the cornea with some injury of the your iris tissue. But the last one is the one that presents a challenge, because in children you have to consider the amblyopic condition of the child post-surgery and also the implantation of the IOL, whether you will be able to implant the IOL in the same sitting or would you like to go ahead in the second as a secondary implantation. So for example, this is an 8-year-old girl who suffered an injury to the right eye 6 years back, and the visual acuity had dropped down to only PL. Even the perception of rays was also, projection of rays could not be seen, interpreted properly. And you can see the adherent leukoma exactly just in the visual axis, just little up of the visual axis, and the pupil, you see how it has been dragged towards the adherent leukoma and it has become a slit-shaped pupil. So in these situations, you need to go ahead with a VEP. You can also go ahead with your UBM or an AIOC to see the structures or the lens behind. Gonioscopy, however, did not reveal any recession or broad base past in this child. There is an exotropia because of the amblyopia that has set in. So a planning of pupilloplasty membranectomy was done, and we thought that we'll go ahead with an IOL implantation and anterior vitrectomy in the same sitting. Now, since we were going ahead with this procedure, we took into account what the condition of the endothelium was, because in these cases it is better to avoid the ultrasonic power for the patients, because you see the CV ratio is very low, around 28. Now, the ultrasound, in the ultrasound of the eye, you can also take hint about the cataract. Now, membranous cataract is another form of traumatic cataract which presents as a challenge. In this situation, you can see the, I'll put on the arrow. The arrow that, this spike that should have represented your lens is absolutely going down. Now, in these situations, you do not have the lens thickness, you do not have the PC morphology, so it becomes difficult to assess. So we have to be ready in these situations that if you are planning for an IOL, then if the IOL is a 3-piece IOL and then vitrectomy system. So for youngsters, vitrectomy, anterior vitrectomy or learning the vitrectomy system is essential to go ahead. Now I have done an anterior limbal route. I have made a 3-port so that I don't need to make more nicks later on. So under the OVD coverage, cohesive OVD, I have done a stretching of the pupil so that at least I have some view of the cataract behind. Now you see the stretching I have done not in the same meridian as the adherent leukoma, but opposite to it. After a little bit of viscodilatation, I went ahead with the cutter. Now when I'm using the cutter, I'm bound to cut this fibrovascular tissue and the redundant tissue, so there is a bleeding in these situations. Now you feel the adhesion as you go ahead, and then you plan the cutter or the scissors, micro scissors that you would like to use. Now when you are cutting this fibrovascular tissue that is adherent to the cornea, you need to have the endocautery in your armamentarium when there is a bleed. So now I feel that the superior end is almost released. So I will go ahead with the scissors, micro scissors, to release the terminal end. So you see, it is already released now. Now, when I'm cutting the redundant tissue and forming the pupillary margins, you see there is a bleed. So use the endocautery as and when required so that you get a good feel. I have put in adrenaline because the inferior end of the pupil had maintained the sphincter and the dilator muscles. So I went ahead with a peripheral rhexis with the microcapsular forceps. Superiorly it was difficult. I finished it as a hemirhexis and then I completed with a vitrectorhexis. Vitrectorhexis and continuous curvilinear rhexis has got its strength and its drawbacks. And with the same cutter I went with the aspiration. Now the advantage for me here was that I had already made 2 ports before. So while maintaining the AC, I went ahead to complete my case. Now, since I knew that I had the peripheral rim, that is the tire shaped rim of the bag, so I went ahead with the IOL implantation in the bag. Now, I made the wound a little larger so that it is easy for me to maneuver the 3-piece IOL into the bag, sutured it up with 10 of vicryl, and now I have planned for the PC to address the PC. So when you are using the cutter, you have to place the mouth of the cutter, that is the opening of the cutter, down and not move it too fast because this vitreous is liquefied and you need to be very careful about this vitreous. I only excise the last strand of the fibrous membrane because if you pull too much in the beginning, then you are going to cause tension in the bag and you might end up with more complications later on. So before the last wound suturing, I have placed air bubble, and that's how I finished the case. So this is the post-operative results of the child, and she has counting finger 1 meter. The CV at that time was 28, now it has gone down to 22. However, it has maintained its hexagonality, and the fundus picture is quite, we feel happy with the child having regained his vision, and we would go ahead with the rehabilitation of the child. Now, proper planning is important in these cases. That is the message that I wanted to give from this challenging case, because you have done a good cataract surgery in traumatic cataract, especially in membranous type. But you see the yellow arrow that I have pointed is that if you have not released the adhesion, then you end up with occlusion of the visual axis, the primary visual axis, and the brilliant surgery that you have done does not actually serve any purpose. So the photos on the top are some of the situations where you can end up with extremely difficult, more difficult cases. But the message is only proper planning before going ahead with the surgery, because it's not the skill of the surgery, but the planning of the surgery that I believe in. Thank you so much for your